Good afternoon, everybody. It is my honor to share with you today what I have learned in my journey since crossing over to ICU, from ICU to palliative care. Today, I'll be sharing with you my perspective on how can we as nurses improve on our care for the dying. In my years of working in the coronary care unit, I have realized that sometimes, no matter how hard we try, doing our best is simply not good enough. While the complexity of care in the ICU continue to advance and grow with sophistication of technology, one thing remains constant: death. Death remains the constant that we cannot defeat. The only thing that we can do is to change the course of the journey leading to it. As we know, the principle of airway, breathing, circulation, and drugs sums up the fundamentals of ICU. Let me introduce to you another set of ABCD that we should incorporate into our daily care in the ICU. Although this ABCD concept, otherwise known as dignity-conserving care, originates from palliative medicine, it can be applied across different spectrum of healthcare. First, reflecting on our attitude. Our attitude, perception, and assumption affects the way we provide care by influencing our approach to our patients. We have to be mindful of how our attitude shapes our behaviors and reflect upon ourselves constantly. Questions we can ask ourselves include: why do I feel so towards this patient? Will my attitude hinder my ability to treat this person objectively? Once we are aware of our attitudes, we can then start on modifying our behaviors, which should be built on the basis of respect and trust. Random gestures of kindness help personalize care and establish strong rapport. For example, fluffing their pillows, placing the tissue box within reach, acknowledging personal items in the room such as cards, photos, or simply a wave before leaving our shift. All these simple gestures helps to create a sense of importance to the patient who feel they matter enough to warrant our attention. The essence of patient care lies in compassion. Compassion isn't an acquired skill, but a feeling. This feeling is a deep awareness of the suffering of our patient, coupled with a desire to relieve it. Showing compassion can be as simple as a reassuring touch, a gentle smile, and a gentle look. We should hold dialogue that acknowledges our patient personhood beyond the illness, knowing our patient first as a person who is ill and not as an ill person. Now, with this ABCD concept, let us look at our role in caring for the dying. As ICU nurse, we are there with the patient round the clock. While carrying out routine ICU care is almost instinctive to us, how can we help patients and their family when aggressive ICU care is no longer the priority, recovery is no longer the goal, and death is soon approaching? In a paper published in 2011, Nelson et al. Said, critical care nurses are a valuable resource to improve and address the needs of patient and family facing life-threatening illness in a variety of settings. Preparatory work starts at the recognition of the dying process, and fellow staff, patient and their family, and the ICU environment needs to be prepared. We can prepare the staff by letting them know a patient is dying and to recognize the grieving family and be sensitive to their needs. We prepare the patient by achieving good symptoms control, ensure they remain presentable and tidy to uphold their dignity and protect their modesty. Facilitate spiritual, religious, and cultural needs whenever possible, such as dabbing lips with holy water, keeping prayer radio by bedside, and keeping money in their pockets. We prepare the family by providing consistent and constant update of patients' condition. We explain and preempt them on the signs and symptoms of dying. And we prepare the environment by ensuring comfort within the room. Taking a leaf out from the book, 4 Things Which Matter the Most, we can remind the family of the importance of saying, I love you, I thank you, please forgive me, and I forgive you. Thereafter, allow the family the space and privacy to grieve and consider getting our MSW involved to provide the emotional and post-bereavement support. There is no better way of learning than precious lessons from our patients and their families. Next, I'll be sharing with you 2 of such stories. We first met Mr. Lim in the MICU, a gentleman diagnosed with stage 4 CA lung. As you can see, things are not exactly looking good for him. On day 10, referral to palliative medicine was made as Mr. Lim remained ventilator dependent and unable to tolerate any forms of weaning. We touched base with the family and got to know Mr. Lim as an independent man with 2 children. The children were unsure of his view on death and dying. However, they do know that their father was the one who made the difficult decision of having his own brother terminally extubated a few years ago. And in recent days, Mr. Lim was afraid to sleep, fearing of not waking up the next day. And the family felt that Mr. Lim wants to go home. We spoke with Mr. Lim after the conference and explained that he is likely to be ventilator dependent and that his advanced cancer will limit his prognosis. I'm sorry, there's something wrong with the slides. So, in short, we asked him these questions and left him to ponder over it with the promise of returning the next day to answer any further questions. We returned in the afternoon to continue engaging him. When we asked him about his opinion, this is what he did. He nodded when asked if he wants the ETT to be removed, and shook his head when we asked if he wants it now. Then he raised his hand and did this. Unable to figure out what he was saying, so we handed him paper and pen, and this is what he wrote. Family was informed and witnessed a repeated exchange between Mr. Lim and us. Decision was made for extubation 5 days later on day 16. However, on day 13, the family requested for another conference. It appeared that Mr. Lim had forgotten about the extubation. We asked if he could remember our conversation. He wrote. We didn't manage to have any more fruitful conversation with him and ended with him closing his eyes, refusing to be further engaged. On day 15, a second conference was held. Family then requested for us to speak with Mr. Lim. So I asked him this. We assured him of good symptoms control and being there with him throughout the whole process. Then we checked with him once again. We asked him how he felt towards the ETT and he wrote this. We asked him what is he fearful of. He shrugged his shoulders and wrote. Then he drew this. Meaning, we live to die since the day we were born. He then asked to think for 1 more day. Overnight, Mr. Lim became more breathless. Despite this, he wrote to his family that he wants the ETT to be removed. He was calm and alert and managed to sleep until the morning. The next day morning, we asked him if he remembered what we are going to do today. And he did this. And we asked him again. He shook his head. His loved one had already all visited him. We went on to ask him this. He pointed to his family and motioned this. After his son correctly figured as that is him asking the family to remain united. After hearing his son's promise that they will look after his mother and stay united as a family, Mr. Lim wrote this. Mr. Lim was able to enjoy the aroma of his coffee and as requested, and his children dabbed his lips with coffee and Coke. Mr. Lim then gave us the go-ahead to extubate him. 2 hours after extubation, Mr. Lim passed away peacefully, surrounded by his family, with his wife holding his hands. Our second story is about Madam Wang and the Teo brothers. We first knew Madam Wang in the ICU when she was admitted after undergoing e-op for perforated gut. She had a stormy stay with many complications. Madam Wang was referred to palliative medicine after she had suffered another stroke. Given her advanced age and multiple coexisting conditions, her prognosis remains grim. She was barely responsive, stirring only occasionally to pain. There was little chance of her being able to tolerate extubation. We held a family conference on the same day to know Madam Wang and her family better. She was a doting mother of 2 sons with 6 grandchildren. She remained fiercely independent despite suffering a pontine bleed 10 years ago. The family felt that Madam Wang is a fighter. The The aim of our first meeting was to pave the way for the family to understand the trajectories of Madam Wang's condition. The ICU team also shared that Madam Wang was likely to be ventilator dependent. During the conference, what strikes me the most was how the brothers differs in opinions and approaches, and the granddaughter's questions. The team assured that they would do their best for Madam Wang and further meetings could be arranged. However, on day 10, the grandchildren asked for a meeting again. Sarah shared with us about the grandchildren's concern. They were all very worried over the two sons, given their different views on Madam Wang's care. The grandchildren decided that another conference should take place on day 13. Day 13 was the day when the family will decide on trachea or extubation. Tension can be felt during the conference, and both brothers remained stoic with zero interactions. The grandchildren were nervous and had pre-warned us that the conference might end up in a shouting match or worse, fist fighting. At the end of the conference, I remember the anesthetist told the family this: "Let us put aside our differences and come together as one family to make the best decision for Madam Wang, a best decision made out of our love for her." Much to our surprise and everyone's relief, the elder Mr. Teo agreed with his younger brother on terminal extubation. He felt that a life of dependence will not be acceptable to Madam Wang and does not want his mother to suffer anymore. The family decided to have Madam Wang extubated the next day. The next day, Madam Wang was extubated and she was stable enough for transfer to general ward where we continued to review her. The following day, I met the elder Mr. Teo. He asked me why is Madam Wang lingering on, and I said that perhaps Madam Wang have unfulfilled wishes and worries. That afternoon, I received a photo from Sarah.
They held my grandma's hand together, and that was the first time, I think in a really long time, that the three of them could actually be together peacefully without fighting. So my father held my grandma's hand, and my uncle held their hand. For the first time, my grandma actually responded. In her entire ICU stay, I don't think we have seen her really respond that much. She actually cried, and she nodded her head.
It has been her wish. Yeah. I just think that I shouldn't be so stubborn. Why wait until that moment?
Madam Wang passed away minutes after this photo was taken. The story of Madam Wang and the Teo brothers amplified the importance of four things that matters the most, and taught me that forgiveness is the greatest and final form of love. Personally, I felt it is a privilege to witness such moments of my patient and their family, and these are lessons which I will deeply treasure. I would like to end with this quote: "May we all hold these words close to our heart, and that is to cure sometimes, treat often, and comfort always." I thank you for your time this afternoon, and please forgive me if my sharing was inadequate. Thank you.